Okay, so our scenario is you have a 15-year-old high school volleyball player who's in the club and who is right-handed, complaining of low back pain. A little more on the right side, she is an outside hitter and she is unsure of the mechanism of injury. It has been hurting all summer long, worse with hitting, and it gets tight pretty regularly. The onset has been gradual for about 2 to 3 months and lasts about 24 hours after each volleyball practice. The pain is usually dull, achy, but can be sharp while hitting. It feels better when lying down. There are no radiating symptoms, and pain scale 4 to 6. Cool. So I guess to kind of start this off, I would ask what kind of movements specifically are really bothering her. She kind of mentioned what's bothering her in practice, which is hitting. I'd want to know kind of outside of practice activities of daily living, what's kind of bugging her.
Okay. I will ask, can she point out the most painful spot?
Something else I would ask as well is how has she been trying to treat this? Maybe she's taking medicine, or maybe she's been icing at home.
Okay, and does the pain change throughout the day? Yep.
I'd also ask if she notices any like differences in sensation. So maybe she can't really, her right side goes kind of numb, maybe the left side's fine. Those are things that I would want to know.
Okay, I will ask, does she have any past low back pain or any past lower extremity injury?
Right.
Also, any past medical history?
Mm-hmm. I guess, yeah, with that specifically is any surgeries that she's might have had on her back. Maybe not just in the back, but any like extremities. Something else you could ask is like what provokes it, but what also makes it better. I know she kind of said that when she lies down, it feels good, but maybe are there any stretches that she likes to do before practice that make it feel better at all?
Okay, and the last question is about any bowel bladder changes or problems.
Mm. And then, yeah, I guess, yeah, that's good. Another thing to ask is, has she noticed like her performance slipping at all, or any decreases in strength? Cool.
Yep.
And then moving on to observation, what would you start out with?
Me, I will start from the gate, about any short steps or shuffling or slouched. Yep.
That's good. Like when they're walking into the athletic training room,
Yeah.
are they walking at all like awkwardly? Yeah. Uh, Something else I would look for is kind of like their posture, just kind of how they're standing, seeing where their hips are, their shoulders and head, seeing if it's aligned or if maybe their head's pushed forward, shoulders are pushed forward, especially like the anterior pelvic tilt, seeing if it's either posteriorly tilted or anteriorly.
Okay. So you mentioned the posture. Mm, so I will observe the standing position, also the posture, and they shift to one side.
Mm-hmm.
Yeah,
That's good.
and also the curve, right?
Yeah.
Yeah.
It'd also be good to see not just how they stand normally, but maybe even at practice, kind of how they stand in their position, and seeing if there's any things that may be causing their pain from that.
Yep. And I will also observe the movement and the willingness to move their body.
Yeah, that's good. Seeing if they're like kind of apprehensive to any movements in particular, whether flexing, extending, rotating.
Yep. And I will observe any step deformity.
Yeah.
Yep.
Adding to that, also looking for any like scars. If they have any scars or markings on their body.
Yeah. I think I cover everything in observation.
Mm-hmm. from observation going into palpation. Um, I guess the first thing that we start out with are bony landmarks. So I'd probably go to the iliac crest. Obviously, if they're complaining of pain on the right side, I'd probably start on the left side and start off with the left ASIS and then go on to the right side.
Okay. So we'll start from ASS and either crest and PSS. It's like a curve.
Yeah.
And I will move toward the painful spot. So I need to know which spot is the painful spot.
Mhm.
Then I will move forward and palpate the spinous process of each vertebrae.
Yeah,
Yep.
starting from the cervical, you can go through the thoracic and then through the lumbar
Yeah.
area, kind of feeling the spinous process. You can try your best to try and touch the transverse process, but we also have that musculature that's kind of in the way on the lumbar area. So even feeling like the erector spinae muscle group, working away from like the neck all the way down to like the lumbar area, seeing if that has any tenderness.
Yeah. Should I move to ligament?
Yeah.
Um,
Before we go to ligament, you can also ask them like, does it feel deep or superficial?
okay. But for ligament, I think we only can palpate for the supraspinatus ligament.
Yeah, it's gonna be it's gonna be pretty difficult to palpate through there.
Yeah. So for a palpation, we're going to look for any spasm, an area of pain. I think it is called the tension of the muscle.
Mm,
Yeah, maybe the crepitus
mm,
to cause some fracture.
mm.
Yeah,
Because like you just said, like touching them can make them spasm, pushing down in the area that's sensitive. They may also tell you like when we're doing like our eval, like saying, does this feel the same as this? They might even say, oh, I don't feel that. That's something else to look out for. Also,
yep.
maybe numbness or tingling, maybe even burning as you go through there.
Or maybe radiate to other area.
Right.
Okay, so move on to active range of motion.
Mm-hmm.
Start from the standing position.
Mm-hmm.
Also start from the least painful movement.
Mm-hmm.
So, okay, so we're going to look for any instability jog. Yeah, which may indicate the unstable segment. So I'll do extension, flexion, lateral flexion, and rotation.
Mm-hmm.
Yep.
And then going through doing the exact same thing through passive range of motion. May be a bit difficult to kind of hold the torso in your hand and go through those motions, but maybe the athlete can assist you, or you can even like for passive extension, you can lift the legs up while they lay prone, and that's also good for. You just gotta be a little creative when doing like passive range of motion. And then after passive range of motion, we can go into resistive range of motion.
It's also really hard to do.
Yes. Also, something else to look out for is if, say, they're having a really difficult time doing active range of motion, and it not only is it difficult but very painful for them, you may not even want to do passive or resistive range of motion.
So maybe we can move to the manual muscle test.
Yeah.
So I'll do it for the groups from the flexors, which may include the ab muscles and also the hip flexors.
Mm-hmm.
Yep.
And you can even do the extensors, which would be like on the posterior chain, doing the hamstrings, the glutes, and the erector spinae, which will assist with that.
And also the lateral abdominal endurance test. The side, what is that name? Side plank? Yeah, that one.
The obliques, the internal and external obliques.
Yeah. And move on to the lower quarter screen, the dermatomes, myotomes, and reflex.
Yep. Do you want to kind of talk through that, I guess? Oh, I guess it's a little bit difficult to kind of show.
Yeah.
Yeah. Um, okay,
Maybe
so
we can say how to demonstrate, like dermatomes X which parts we're touching to compare,
yeah.
and the myotomes hold for 5 seconds and reflex to look for the slightly movement.
Mhm. And
Yep.
in those 5 seconds, we're looking for seeing if they kind of have weakness throughout it. So maybe at the start of it, they have full strength, and then at 3 to 4 seconds, they're saying like, "Whoa, like they have significant like weakness or any weakness at all."
Yep. So I think we can move on to special test.
Yeah.
Okay. So first, I will do the quadrant test to ask the patient to extend and is that rotate
Hmm.
and lateral flex. Oh my gosh. Let me see.
Another one we can do is
Okay.
the Valsalva maneuver, which
Yep.
is kind of you just have them like they're doing a back squat, and they'll take a deep breath in and they kind of push out, and in that they're kind of looking for pain and asking the location of pain as well.
Yep.
Um,
And wait, let me see. I will do the straight leg raising test.
mhm.
Yeah. Just raise your leg and see the symptoms
Mm.
to reproduce on which degree. They got 30 and 70 and indicate different injury.
You can tell if it's either muscular based off if they have no range of motion, or maybe when you
Yeah.
start doing it, they say like, "Whoa, like it feels super tight and like my leg's going numb," which could
Yeah.
be muscular and neuro, or just neuro. Another test we can do is I think it's part of the upper quarter screen, but I mean lower quarter screen. Checking like neurological tests, you can do the Babinski test, and it's you swipe the bottom of the foot, and they should I think they should flex the toes down, and that's normal. But then if they extend their
Yeah.
toes, splay out, then that's I believe that's a lower motor neuron lesion.
Mm-hmm. And I would do the prone segmental instability test, which do the PA glide first while their feet is on the floor. Then ask them to lift the feet off the floor and do the PA glide again to see whether the symptoms is decreased. Yep.
And, another test to use is the slump test, and this is to check the sciatic nerve. Um, you'll have the patient sit at the edge of a table, and they'll have their hands behind their back. They're sitting up straight, and legs will be hanging off, and then they will. You'll have the athlete look down, and they will lift the leg, extend the leg that you believe the side is on. You can try the healthy side first and extend out. And if there's no nerve complications on the healthy side, that should be expected. So you'll do the injured side. And when they do that, if it is sciatica or any kind of sciatic nerve problems, then they'll have those neurological symptoms or the symptoms that they complain of.
Yep. And I will also do the Milgram test. So the patient is performed a bilateral straight leg raise about 2 to 6 inches above the table and hold that position for 30 seconds. So the positive sign is if the patient's unable to hold that position or unable to raise the leg or reproduce the symptoms. Yep.
Another thing we can do is try and use tension. But it's kind of like distracting. You can either try and distract like the hip joint, maybe the pain's in there, If not, you can pull like on like the legs. I know in Valley Down they had that tension machine where an athlete would sit down. It was kind of like a belt that looked like it was gonna separate them. You can use that as well, and it like separate. It kind of like tenses like the vertebrae, and may relieve some of the symptoms if there were like such thing as like a herniated disc or any kind of compression in the spine. It might relieve some of those symptoms.
And I think I would do the muscle tightness test, like the Ober test or the Thomas test, to rule out some muscle tightness issue. Yep.
Good. And then, I mean, I think that's all the special tests that I have.
Yeah, me too.
Okay.
Almost.
Then after doing the special tests, depending on what they test positive for, what they test negative for, it would push us towards our assessment. And then hopefully we have DDXs for what is wrong with this individual. Most likely they're going to need imaging. So refer them out to doc to get that. As far as therapeutic exercises and stuff go, we haven't taken that class yet. So most likely we'd have to see what doc has to say and what imaging we get back and have to go from there. But if there's anything else you want to add, Ping, I think this kind of concludes our evaluation.
I think we should find out which movement or the posture can alleviate the symptoms. So we can try to give there some homework, which is focused on the movement that will not increase the symptoms, and try to avoid the movement that will produce the symptoms. Yeah, that's it.
Cool. Okay, I will stop this video then.